Hello everybody, my name is Anastasia Rachmanidou, or Rachmanidou, and it is a pleasure to see you all here. I would like to thank Yannis Konstantinidis for his invitation, giving me the opportunity to give this talk, and Vizke Fokins. It's been a dream to have this conference in Thessaloniki. I did try for this. I'm very proud we're here today, despite the odds. So I'm from Thessaloniki. I was a student in the Aristotelian University, and now I live and work in London. This is where I work, in Lewisham Hospital. On not a sunny day is the photograph, as unfortunately we enjoy here today. So I have been given the task to talk to you about pediatric septoplasty, and it is not an easy subject. Probably it's not an easy subject because it has been a taboo for years not to touch the pediatric septum. So I remember myself as a young trainee going to conferences, listening to people talking about septal surgery in children, question mark, should we do, should we not do, when to do, how would that be performed, and thinking back all these years and looking ahead, have we changed at all? So I will try with my talk to just have a look at the literature, look at the evidence, and see, have we changed? And if yes, how? So there are some absolute indications on performing this surgery, and the absolute indications are to debride after a septal hematoma. We have to clean a septal abscess. When there is a very severe nasal or septal deformity following trauma, when we have congenital anomalies for cleft and lip and palate surgery, and there are stages, or when we're dealing with nasal tumors. But what is it that we see most commonly in our practice? Actually, most commonly in our practice, we see the septal hematometer, but we see nasal airway obstruction. It is the child that will come with a coexisting pathology, possibly allergic rhinitis, possibly chronic rhinosinusitis, and a bent cartilage in the nose. And also we might see a progressive growth deformity. So this is a relative, but a very important indication. I would like to give credit to Professor Karel Verweerd and his research, and I would like you to just have a look at this publication from 2010 on rhinosurgery in children. It doesn't explore only septal surgery, but in general, nasal surgery, so septorhinoplasty in children. And it is very important to keep that in mind as introduction, that the nasal skeleton of the newborns are totally different from the adult nasal skeleton. So we have a lot of cartilage that progressively becomes harder, more sturdy, it becomes ossified later on in life, but early trauma then causes significant deformity as the nose is growing and it is reaching maturity. So in the pediatric nose, there are two main growing areas that we need to be aware of and respect. And these are the sphenodorsal and the sphenospinal areas. And I would like you to excuse my drawing. I didn't want to reproduce it. So I will try with a pointer. So the sphenospinal is this area. If we think that this is the vomer down here, this is the ethmoid, the perpendicular ethmoid plate, maxillary crest, and back here to the vomer. Here it is the sphenospinal and the sphenodorsal up here. And also, this is a very delicate area, very, very flimsy cartilage. It is not strong. And then we are comparing, in this slide you can see views of MRI scans from a neonate and a 3-year-old and an adult nose. And you see also clearly the extent of the cartilage in the young child and much less in the adult, and extensive ossification in the back. So totally different anatomy. As they say, there is far more brain in the child and far more face in the adult. So these are my questions. How can you restore normal growth of the nasal skeleton when there is loss of cartilage, particularly following a severe septal hematoma? How can you treat acute nasal or septal fractures in order to prevent a further abnormality during growth? And how can you intervene in the development of the nose when the anomaly is obvious? Going back to the literature, first publications from Pearson in 1984, when he looked at 3 different cases, 3 children that then he reviewed in the age of 16 years of age, and the child that had an injury in the age of 3 had more significant deformity, and the child that had an injury at the age of 5 years and the child that had the injury in the age of 7.5 years had less of a deformity later on in life. So there are significant differences depending on the deformity that we have later on in life, depending on the age of the trauma. Different papers, again, different views, and there is no evidence based on that. And looking at literature, most of the papers say, oh, the nasal growth should be completed by age 16 in boys. Possibly a little later. But a study in Turkey says, oh, the girls are fully mature, age 12, and maybe boys are mature after the 15th year of age. Going to Switzerland, in Central Europe, you will have a different opinion. And then they say, well, the nasal growth is continuing still above the age of 20, maybe in females, and 25 in males. What I see is that, well, what we tend to do in the UK is we avoid septorhinoplasties unless absolutely necessary below the age of 17. Now, where would you do septal surgery? Would we do it over the age of 15? Thereabouts? Safe earlier? So, previous early publications before the 60s say, no, don't touch them. And probably most of us have been trained not to touch them. But in the recent 60 years, as we have developed not conservative thinking, but conservative methods of surgery, then we became more adventurous. And I think we are more safe. So I will give you some other articles. Publication of 2018 by Sarah Kina, and this is exploring the approaches. Is a closed approach better than an open approach? Should we use grafts? And the author endorses the view that there is no issue with the mid-facial development, and they use open approach and they use grafts. Now, a very good systematic review published in 2020 gives us an overview of 8 studies with evidence base. And out of this, but still, they are anthropometric studies, so they just measure these children as they were at the time of the surgery, and then they measure nasolabial angle, other dimensions, and then they compare later on in life. Are they strong enough in the level of evidence? Not really, up to level 3. And the best study is number 3, as you look at the first column, and it is the study by Tasca from Italy that was published back in 2011, because this study is looking at 44 pediatric procedures. Half of them were done endonasally, and half of them were done with an open approach. And he has the longest follow-up of about 9.5 years post-surgery, and he doesn't find any significant impact in the growth of the mid-face apart from the nasolabial angle. So there is possibly, this is the best evidence that we can provide. But now we're not looking only at measurements, but what is the impact on the quality of life? What do we do for these children? I mean, children are brought to us age 5 with a completely deviated columella. What do we do? Is it important? Is it important for the parent, or is it important for the child? We are looking at evidence again in publications. Not always the quality of life improvement correlates with the surgical outcome or the measurements. So sometimes you have a better quality of life outcome despite the fact that you don't have such a great aesthetic improvement. So the only study looking at this is available from 2017, and it is looking at a short-term quality of life outcome, looking at 28 patients. Importantly, female patients report better outcomes than male patients. And again, depends, we have to analyze what age group these children were questioned and what is important to them. What is the additional benefit? So, in order to summarize and clarify things, in septal hematoma, and in order to prevent septal abscess, we should promptly drain under GA. I prefer to suture flaps, and I would suggest a soft packing. Absorbable is preferred in order to avoid traumatic experience pulling packs out. In nasal trauma, prompt reduction. So would you do closed reduction? Yes, as soon as possible. It is very difficult also to assess in the pediatric nose. You might have to have 2 meetings. Sometimes there is significant edema. The elasticity of the facial bones in the younger, and the gross edema does not allow a good assessment of the deformity, and maybe you need to see the child 2 or 3 days later when the edema has subsided. But we have to do what we have to do. We have to keep in mind that the perichondrium is very, very fragile, so extra care needs to be taken. And later on, if we cannot correct the deformity, because a deformity that can be due to a nasal trauma, possibly from 6 months ago or a year ago, may need an endonasal septoplasty or an open approach, that should not be completely excluded if following the reduction we don't have a good outcome. So what do we do? How do we do it? Do we use an endoscope? I have done so, but I have used a pediatric autoendoscope, and it is brilliant in the nose, and you can have a targeted excision of a spur without a full, double flap elevation. So unilateral and topical excision of a spur, that's an easy case. We're not talking about columellar deviation. In any case, endonasal or open, you will need to reimplant the cartilage or any fragments of bone that you think they're not necessary. They're absolutely necessary. So just think of the current views of preservation rhinoplasty and put it back and don't take it out in the gallipot. So conclusions. We have to think differently for different age groups. So it is different if we have a severe trauma in the age of 0 to 3 years, 3 to 6 years, and 6+. And of course, life is much easier if you're dealing with a 6+, because the deformity is going to be not noticeable. I would suggest that endoscopic septoplasty is safer with a minimal cartilage removal, maximum 2 to 3 millimeters wide. But we have to avoid the areas that we discussed at the very beginning, the sphenospinal and the sphenodorsal areas. And yes, of course, you will consider an extracorporeal septoplasty, because let's not forget the over 16 or 16 to 18 again falls under the pediatric category. But if you're treating a 15-year-old, you can do an extracorporeal septoplasty. So some photographs that I would like you not to reproduce, please, because they are children's photographs, and I didn't want to cover eyes as their noses would be covered. I want you to see 2 cases of mine. This is a girl that was brought to me when she was 10 years old, because she, at some stage when she was 6 or 7, she had a nasal injury. And as she was growing, her mother noticed that the nose is becoming very broad and bendy. There was not at the time of the first meeting any significant nasal obstruction. So I said, look, it doesn't bother her. Let's wait and see. I took some photographs. You see here a happy child. I'm putting these photographs uncovered because I want you to see the impact in the quality of life as years go by. So you have a happy child, age 10, and you have this child, age 16. And you're already looking at her eyes, you understand that there is a problem there. She's not happy. She's very unhappy. She's very troubled with her appearance. You see that she's growing a long fringe, and she likes, I had to ask her to remove the hair from the face. She likes to cover her face. Again, breathing was not such a big problem, but they insisted that, she wanted to proceed for surgery. So we did surgery, and that was an endonasal approach, and that is quite early following her procedure. It's not too bad, but it is not great. I didn't do any tip work. There were several petals of the septal cartilage, and it was very difficult to decide which petal to remove and how to reconstruct and so on and so forth. But she, at the age of 18, she had an open rhinoplasty. I don't have the pictures of that. Here we have a boy that I met when he was 15, who had a rugby injury when, age 12. And then progressively, we see that there is a C-shaped deformity and the columellar deviation to the right. He's happy. He's 15, but he is not too troubled about it. But he can't breathe. So we discussed that we will wait for a little while, and then they disappeared, and then they appeared age 17, where you can see now the change. He's unhappy, and he needs something done. So what I did for him is an extracorporeal septoplasty with full preservation and rotation of the cartilage and reinsertion, and there he is, and he's very happy. And with that, I would like to conclude. Thank you very much. Questions?
Thank you for your very interesting and helpful lecture. It's really nice to listen to this lecture, because we have to be more conservative if we start to do, or if we are doing septoplasty in children. But how we measure 2 to 3 millimeters wide, because it's very difficult to measure this standard impossible, which you told us.
Literally impossible, I would say. With that, I wanted to say, just look at it and go as little as possible. And if you have to do it, take your 15 blade and shave it.
Okay.
And then even the shavings, you need to look at it, and can you put them somewhere? Can you place them back?
Okay. Any questions?
You can always crush cartilage. If you have dislocation from the caudal end of the septum, and you have this columellar dislocation for the older child, you can just gently crush It is very easy in a cartilage crusher and reposition. Or if you do an extracorporeal and you do a bit of hump reduction, you can reinsert that crushed cartilage.
Just I want to remind you that we have cartilage memory. It's very important to know if you're doing if you're doing rhinoplasty or rhinoplasty in children. You have all the time remind, because after few years you can see the same problems with cartilages. That's why you have to keep yourself. And do you treat, for example, if you have any problems with the nasal valve, for inferior nasal valves, do you treat them parallelly with medical treatment, for example, septoplasty plus medical treatment of the hypertrophy of inferior terminate, for example?
There is always, you see,
yes,
it is
I know
the patient is an entity, and everything is like onion with different layers, and you cannot just treat surgically. You have, many times I say to my patients, you have allergic rhinitis and you have a bent cartilage in your nose. You have a door that is half open and you have a lot of padding on it. We have a lot of foam. We will shave the foam, but I need to open the door. And yes, many times I respect the pediatric turbinate, but there are times that I will do coblation. I do coblation reduction of inferior turbinates.
I'm asking for medical treatment for the audience.
All right, medical treatment for the audience.
Coblation is other question for coblation, because you are doing scar, and you know the terminate has to work, and we have mucociliary transport.
No, that is submucosal reduction.
Okay.
It is submucosal reduction. And of course, you will treat the rhinitis. If there is rhinitis, you will start from nasal douching. You will start from the simple things that you have good evidence. So you will do the nasal douching. And of course, if the child is allergic, you will treat the allergic nose. And of course, you would have done your adenoidectomy and so on and so forth. It's a stepwise approach.
Okay. Thank you.
Thank you.
Thank you.
Sorry, Professor, Doctor, never mind. Yes, excellent presentation. One more comment about the perichondrium. I think is a very important point for the child.
The perichondrium is flimsy. It is extremely flimsy, or it varies. Recently, I was doing a 10-year-old. I needed access to the sphenoid, and I didn't have any intention to work on the septum, but I had a spare. And it went into pieces. You know, you don't know. You don't know. So you have to use otological instruments, which use an elevator that you use for doing meringoplasties. Use your endoscope more.
Okay, thank you.
Thank you.
Thank you for your excellent lecture. And we will continue with Professor Yuri